Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
This is Dr. Candace Pierce with Elite Learning by Calibri Healthcare, and you are listening to our Elite Learning podcast, where we share the most up-to-date education for healthcare professionals. Thank you for joining us for this podcast series topic on conscientious objection and patient care. I'm joined by Dr. James Stowe, a registered nurse and a Juris Doctor from the Stanford University's Cumberland School of Law. Jay, thank you so much for joining us for this topic.
Excited to be here. Thanks so much for having me.
Yes, absolutely. I really want you to start us off with the why. Why do we need to talk about conscientious objection and understand it? And why do you think it really became a big topic or a bigger topic through the COVID-19 pandemic?
You know, as we think about ethical decisions, which I would classify conscientious objection as an ethical decision in healthcare, we have to consider, where is that coming from? Why today versus years gone by? And I think it all has to do with where our ethical foundation has kind of come from, right? Where has it transitioned from? If we think back years ago, we have the Hippocratic Oath, right?
Right.
So Hippocrates, around 400 BC, developed the Hippocratic Oath, and it basically said for physicians, and I'll paraphrase it, pledge to prescribe only beneficial treatments according to that physician's abilities and judgment, refrain from causing harm or hurt, and to live an exemplary personal and professional life. Like, it really extended outside of just their confines of an office. And we kind of know it best today as the oath our medical students take. Right. Well, when you look at it and you look at today compared to years going by, the oath has really been chipped away. It's really been amended. While 98% or so of our medical students still take an oath, and we even have an oath for nurses. There's a Nightingale oath.
Yes, I was going to bring that up while you're talking about it. And that one was written in 1838, and it was named in honor of Florence Nightingale, but it was actually written in Detroit, Michigan. And that one has also been changed multiple times, but our nursing students still take an oath, a pledge.
They do. They take a pledge. And when you look at these things together, kind of all these disciplines are taking this oath, and we think, hey, do no harm. I guess it's 3 words. It's easy to remember. And that's not necessarily the foundation of these oaths anymore. It's really interesting. They, we've taken things out of them. The original oath, for example, has a comment in there, or a phrase in a quote, and it says, "And in a like manner, I will not give to a woman a pessary to produce abortion." That was in the original of Hippocratic Oath. Do you think a hospital, a university or a college is going to allow their students to take a stand or a pledge one way or the other, regardless of your belief, on such a contentious issue? They're just not.
No, not at all.
Not at all. And so then you look at that and you think, well, what about legally? Well, when you take this oath, we all have this belief. Doctors, you take a Hippocratic Oath. Nurses, you take this oath. When you get into court, it's real simple as an attorney to say, hey, look, you pledged to do no harm, and you did harm. So even this do no harm language has been amended. So I say all this to say that the ethical foundations that we have, that we used to have, kind of this collective belief, has really eroded. And I think COVID-19 has kind of brought that to the forefront, where our personal beliefs now more than ever dictate our ethics, and it's not so collective anymore. It's very individualized, and that's impacting how we provide healthcare. and it's impacting whether or not our healthcare is truly patient-centered or not.
Right. Is it patient-centered or is it we-centered? But I think that also highlights why it seems like it's such a gray area. Conscientious objection to me seems very gray. And I don't understand where the line is drawn between my personal beliefs and my duty to take care of, to provide care.
Well, it's a great question. And the answer is not very many people know that answer either, because it's a very difficult situation. So you take a look at it, and our country, which was founded on religious principles, right?
Right.
It's very difficult to disagree with that point. So our court system, our country founding had all these religious principles. And you look today in religious, it's kind of hard to judge, like, who is still religious today? What kind of, that's a difficult question. Kind of an oversimplified way of looking at that is church membership.
Right.
Right. You look from the 1930s to roughly the year 2000, and while it fluctuated up and down, about 70% of the U.S. was a member of a church, one church or another. Since 2000, that number from 70% has fallen to 47%.
Wow.
So in a very short period of time, we've kind of gone away from a collective belief to more individual beliefs. And why is that important when we talk about the healthcare professionals' personal beliefs? It's because those healthcare professionals have their personal beliefs now. Okay, they no longer have that collective belief. From a healthcare standpoint, our oath has deteriorated. Our religious foundation we've stepped away from that, and so now we really look at things in kind of what are our experiences, right? What's the 10-minute YouTube? What's the TikTok, the 5-second Snapchat? What is that teaching us and telling us? And we're forming our beliefs from there. Very influenced society. So when you look at this and you try to go, hey, how do I correlate my own personal beliefs with the legal system? It's very difficult. Very, very difficult. We recently had a huge decision in 2022 where the U.S. Supreme Court overturned Roe v. Wade.
Yeah.
That was, I haven't heard that much outcry over a U.S. Supreme Court decision in quite a long time. As an attorney, it's very interesting to me because what the court system did is it said, basically, look, we don't believe the federal government has the right to decide this. We don't think that's under the federal court's purview. We think that's a state's right for decision. So many people said, hey, Roe v. Wade, it banned abortions. It didn't do that. It actually kind of more followed the Constitution and said, hey, if the powers aren't expressed to the federal government, they go to the states to decide. And so the states decided. And some put very, very constrictive bans on it. I live in Alabama. We collectively as a state have such a ban that we had laws just in the waiting to kick in, when it was overturned. So they were ready and willing to stop it from the get-go.
In Texas, I saw they just finished the first lawsuit where a pregnant person sued to try to have an abortion because they found out that there was something wrong with the baby, and they said no. So she had to go out of state in order to get the abortion. So,
and that case is interesting. I was listening to that case, and from a legal perspective versus healthcare, so let's say that states, and Alabama does not have this. So let's say, and Texas does have this. And this is part of the issue. Texas said, you know what, if there is life-saving, if the mother's life is at risk and we need to do life-saving measures, then abortion is okay. No one will define what is a life-saving measure or when is the mother at risk.
Right.
So we don't have clear guidelines. There are no clear guidelines. In this particular case, and you forgive me, I don't have all the facts in front of me, but in this particular case, I believe the mother did some testing, and the child either will not be viable, or there'll be some very be very
Severe.
affected, some severe effects on birth. So is the mother's health truly at risk? Is her life in jeopardy? And debatable. I'm not a physician, so I don't know. But that's part of the problem. Is we all have this feeling of, from healthcare providers, hey, I want, if the mother's life is at risk, absolutely save her life, right?
Yeah.
But legally, where is that line? And we don't know. The bottom line is we don't know, and we've got to figure that out. And unfortunately, that's going to go through many, many lawsuits and many judges' interpretations until we get there.
So how many physicians and nurses are going to say, no, I'm not going to be a part of that. I'm going to object to that and not even necessarily because of ethical and moral issues, but because of, I don't know where the line is. So I'm going to object so that I don't cross a line that I didn't know was there.
If you take a step back and you look at it, the smart answer is many of them. Because, and I say that not from a patient-centered focus.
Yeah.
I say that we're a very litigious society.
Yes.
And there's no field that is sued more than, or no individual is sued more than an OBGYN. If we are under this concept that every child is going to be born without any issue, right? It's going to be perfect.
Right.
Baby boy, baby girl is going to be perfect. And if there's anything at all wrong, it's an automatic lawsuit. And so you have that already. That is pure numbers. You can research that. So you have that already. And now we bring this on. If I'm a nurse operating in that area, I have to seriously consider what I do. It's my livelihood, my license.
Yeah, absolutely.
And physicians as well. What happens when they start saying, I'm going to take my conscientious objection and I'm stepping out.
I'm going to go to insurance over here. I know an OBGYN that stepped out and went to insurance. Just stepped out of the field completely.
Yeah. It's very difficult when you work 6 months of the year just to pay your malpractice premiums and to feel good about your work. Right. And at the same time, we need more physicians and nurses than ever. There's a very big shortage. And while all of these things are being brought to the forefront, we have people leaving the field, leaving the practice. Right. And it just makes things more and more complicated. A recent study that I read, it stated that there's going to be a 20% shortage of nurses by 2025.
Yeah.
And I thought, well, that's a tremendous impact. And you can there were different numbers put with it, anywhere from 200 to 500,000 nurses, but either way, that's a huge impact. But the number that I didn't or had not heard before was that there was roughly a 12% increase in demand for care, more acute, more sick patients. So we've got fewer staff, more patients getting sick. Right. So it's a double whammy. And it's really going to affect decisions and how we approach health care.
Absolutely. Now, is there even a way, I know we kind of touched on this a little bit, but to really differentiate between the individual belief as a healthcare worker, as a nurse, and trying to give that patient-centered care?
It's very difficult. It's very difficult.
Well, let's talk about the COVID-19 vaccine with individual care, with individual beliefs versus patient-centered care.
So COVID-19 vaccine is an interesting one. We get this massive scare across the country, right? This pandemic, and COVID-19 vaccine was produced to save humanity, and so we started giving this vaccine, and there's all kind of issues with it. And with it, the rollout, it's brand new. We're trying to do as much as we can, as fast as we can, trying to give it to as many people as we can to save lives as fast as we can. And, the normal steps are kind of bypassed. It's under emergency use authorization, right? So, it's no secret. So
Right.
it gets out there because it's an emergency. There's a pandemic. So now that it's kind of past us, we have all these questions. And I think it's natural for those in the healthcare field to especially ask questions and say, well, let me think about it. What was done? What was done right? What was done wrong? And then it's a very natural progression to go, hey, look, well, I've got to get this flu vaccine, right? There's a flu vaccine that is from, what is it? The flu season in the hospitals, October 1st through March 1st, roughly.
March 1st.
And
Yeah.
so with that, now what most frontline healthcare people don't understand and what most patients and families don't understand is there's actually financial compensation tied up into administration and documentation of this one thing, along with many things. So if the nurse says, look, hey, if I'm the nurse leader, I'm the nurse manager or nurse director, frontline staff nurse comes to me and says, look, I just, after this whole COVID thing, I've got a lot of answers. I mean, a lot of questions, excuse me. I've got a lot of questions and if I could just see a safety study of this annual flu vaccine, I just would feel a whole lot better about giving it, right? Because there's all this controversy with the COVID-19. I don't understand it, but I know there's controversy. So if I could just see this. So you have to sit there and look and say, wait a minute, there isn't a safety study. There hasn't really been a safety study on vaccines in 40 years, but even if you did, how do you do a long-term safety study on a seasonal flu vaccine that changes year after year? It's just
every year.
It's pretty unfeasible to ever.
And the COVID-19 vaccine continues to change. They're continuously putting out boosters. So like, oh, we're adding new strains to it. It's a continual change between COVID-19 and for the flu vaccine every year.
It is. And so you look at that, and as the frontline nursing personnel, it's a very valid question. I want to see a safety study because, again, if we go back to this oath of do no harm, it's hard to marry the two, right? Because we don't have evidence that we're not harming. So when we look at that.
Well, and I just want to point out too, while you're talking about this, is it's almost sometimes in some facilities you get like, and it's like this scarlet letter. You didn't get your flu vaccine, or you didn't get your COVID booster, or, so you're going to get fired, or you're going to have to wear this and a mask. And so that everybody knows that you made a decision following your conscience. Yeah,
it's really tough. The hospitals are, in any healthcare facility, really, it's kind of twofold. We want you to take the flu vaccine, for example, because we don't want you to get sick, one, so we care about your health, but at the same time, also need you here to take care of these patients. And if you're not here, we can't accept as many and the revenue goes down. So it's kind of this, where is the line? Are the hospitals really altruistic, or are they just kind of worried about the bottom line? So what do? They say, you have the choice. You do have a choice to take it or not in most situations. However, if you don't, I'm going to need you to mask up and do all these things that other people aren't, and you need to stand out. Okay?
Right.
So is that really a fair allowance of being able to choose for yourself and be able to consciously object to something? Or are you able to do it with kind of an asterisk of, well, we're going to make fun of you and browbeat you into doing something? And so it's a fine line out there. And I think that's why this thing still persists, is because no one really knows how to really appease all sides. But at the end of the day, if the science says that flu vaccines do well and help people, and the nursing staff is deciding not to give it, what about the elderly immunocompromised in the hospital? Grandkids are going to come see them, and kids are little petri dishes. They bring everything from daycare, school, home, and so we now share all this with grandmother. She gets the flu. Could we have avoided?
Right.
So we have to go back at some point and consider what that patient-centered care really looks like in light of all of these kind of personal ethical issues that are before us.
Right. I want to bring up a couple of examples that I can think of that I've seen happen or, heard talked about within our profession. And I just want to throw those out there and just see are these how these might be within that gray area of conscientious objection. And one of those is you're working on a floor. The house supervisor says that you have to take a immunocompromised patient, but your floor is full of, say, the flu. The flu is hanging out on your floor and you have an immunocompromised patient. You don't have enough nurses to make sure that this person is just dedicated to this immunocompromised patient. And so you decline to care for that patient. Maybe because you have a flu patient and they're trying to give you this immunocompromised and you don't want to share the flu by accident with this patient. Do you have the right? Is that something you can conscientiously object to? Do you have the right to stand up and say, I can't do that?
So it's very interesting. The ability to conscientiously object is pretty protected by law, right? Kind of the foundations are our religious freedom, our freedom of speech, our freedom of choice. It's really embedded in our constitutional rights. So it's pretty supported by most states in their constitutions. What happens, though, is the hospital says, hey, we understand that, but we still have to provide care. So what can we do? So most hospitals have policies that say, you know what, you can object. But I need you to come to HR. I need you to list all of your objections. And we're going to keep that on file. And when you have a situation that arises, we're going to take what you have written down and cross it and make sure they meet. That's a pretty intimidating thing. You take the average healthcare worker to go down, formally write out. And what if you don't include every little situation that arises? I mean, topically, we kind of had an example here. We know topically, okay, I don't want to participate in abortion, for example. Texas situation comes up. Well, did we list mother's choice and mother's belief that she has a terminal situation in front of her or not? Where's that line? So what happens is when we get a patient in, and we say, you know what, this kind of looks like, smells like, feels like that situation where I want to conscientiously object. We do so.
Right.
Nurse manager, nurse director calls HR. They pull the list. They come back and say, close but no cigar, right? This doesn't fall into that exception. You need to do this task. Well, you ethically and morally, based on your religion, are like, wait a minute, I don't feel good about this. So you do have the right to conscientiously object. However, in this instance, you didn't list it. You didn't follow hospital policy. Yeah. So you actually are violating hospital policy, and you have to decide whether you're going to keep your job or do the act. So it's very difficult. The other thing is, on the flip side, if you accept the patient, if you accept the assignment, you accept the care over the patient, you accept that duty, then you've accepted care and you've assumed that you will do what the patient needs. So now, How do you object? It's very difficult. And there's gray lines there, right? You didn't know about what the patient was asking before you got assigned the patient. You do now. So what do you do? It's very gray. It's very difficult. But if you accept care for that patient and you decide halfway through the care, you're doing an action, and halfway through you go, wait a minute, I don't know about that. It's going to be very difficult to defend that because you've accepted the duty, you started it, and now you're stopping and refusing. There's a great chance that you'll be held liable in court for failing to complete the task or failing to help the patient at that.
Right. So I'll throw another example out there. We have a patient who is basically end-of-life care. Physician writes for morphine. But you know that if you give this amount that is written for, it's not a sliding scale morphine. It is an amount of morphine that it's going to continue to decrease those breaths, and she is going to pass on. So really what is happening is that morphine is helping to end the life, not on purpose, but you know that is what's going to happen from experience, and you're not comfortable with participating in that. You've checked with the physician, and the physician, that's what he wants you to give. So that's what the order is. What do you do in that instant? Do you have an option?
You always have an option, right? As the nurse, you always have the options. Now, the truth is you have to weigh your options, because your options can be, or the repercussions, I should say, of your choice can be several things. One, you can just simply be, okay, fine, take this patient, swap with somebody else, report off, and we'll move on.
Right.
We're busy. Let's just swap people and move on.
Go on.
Second is you're going to get yelled at, belittled, harassed, hazed. What does that mean for the future? Are you going to continue to get that? Does the physician that rounds the next day go, oh, yep, there's the obstinate nurse, there's the one over there that won't do anything, won't even take care of her patients. And patients and families are hearing this. Does that happen?
Yeah.
Or three,
yes.
Do you just get fired? And can you afford to be fired? When's your mortgage due?
Right.
When's your car payment due? It's wintertime right now. It's cold. Do you keep your children warm or not? And so these are not easy questions to answer for the healthcare practitioner, especially when you're in the middle of it and you have mere seconds to think about it. And when we think about this whole ethical dilemma, you got to slow down. And that's one of the hardest things. But we mentioned the difficult situations, difficult patients, but also there's fewer staff. There's more acute patients, more need out there, which all of that leads to less and less time to simply think. So yes, you can is the answer. But you just have to know the repercussions for it. And are you okay with it?
So do you have, I know that you have an interesting background and story where you went to school to be a registered nurse and then decided to go be an attorney, spent some time, and you worked with, I'm assuming, medical issues within the law for a while, and now you do hospital administration. So I love that you see kind of both sides of this. You're seeing the legal side, but then you also see the hospital from the inside out. So you're able to kind of pull those together. And what is your perspective? What have you seen inside the hospital when it comes to conscientious objection and how most places might treat conscientious objection?
It really boils down to the executive leadership. And I mean that from not only the hospital staff, but also the physician staff, right? Hospital staff, I say that because the chief nursing officer, most of the staff, 50+% of the staff in a hospital reports up to the CNO. Because again, nurses and LPNs and aides and techs are at the bedside, and that's their line of authority in reporting. So if you have a strong chief nurse, you have a strong CEO and strong COO where the physicians typically report up to, that are all lockstep together and say, okay, look, anybody can stop the line. Let's figure out what we can actually do here to fix the situation and keep the patient centered. As long as you have that, if I object to something I just don't feel comfortable with, hey, next man up, next lady up. Hey, who's okay with this? Hey, I'm okay with this. Great. Y'all report off. Let's move on. Everybody wins. If you don't have that strong leadership that work together, and it's more of a complaint where so-and-so's complaining they didn't do this, and so-and-so's complaining they didn't do that, and it just escalates and the tensions rise and you lose that teamwork, you lose that environment, then it just, the whole culture falls apart, right? People are standing by their ethical decisions. We all have different decisions. We all have different ethical and religious beliefs. So it's okay to stand by them. Just express them clearly, and let's figure out a way around that. And I think if we were to stop and we had supportive environments from top down that would address these changes in real time, we can bypass the hazing, the harassment, the belittling of people who decide to speak up. Because unfortunately, in so many instances today, we kind of resort to name calling and belittling and hazing versus keeping the patient in the center and moving towards, okay, you object, let's figure out how to take care of the patient. Who can do that? And we miss that. We miss that a lot today.
And I think that really erodes the workforce that we do have. We're seeing a rise in suicide for a healthcare professional, especially nurses too. And we saw that through COVID. And I know we attribute a lot of that to PTSD from, the things that they saw, but also how about the fact that they weren't able to follow the things that they ethically and morally believed and felt. I worked with a nurse who it was in the ICU, and she didn't want her patients to die alone. So she would sit in a room, she would hold their hand, and you wouldn't see her until that patient passed away. But not every nurse was able to do that because, hey, I need to talk to my charge nurse. I object to someone dying alone. I can't have that happen. Can you watch my patient? How many people weren't given the ability to feel like to uphold their ethical and moral values as to the reason why they even went into healthcare in the first place? And how does that affect them mentally? I mean, do you think that?
I think it's greatly impactful. And I would even offer so much as the first step to this whole conversation is, do we tell the healthcare workers that they have the right to do this?
No, I've never had somebody tell me, if you don't believe in something, if you are not comfortable. Now, I've had them say, if you're not comfortable, come get me. We'll do it together. Right. But I've never had somebody say, if you firmly do not believe in assisting, and giving this medication that is going to assist somebody and leaving this world, that you don't have to do that. I've never had someone tell me that I didn't have to overstep the values and morals that I have.
And I think that's one of the first things that we have to consider. How far does that go for a healthcare institution to empower its staff to say, I care enough about your beliefs and opinions to ask you in advance what you're good doing? Because the truth of the matter is there's not that many things. If you really sit down and think about it, there's not that many things that people are going to object to. And when you make that short list, how often do those come up actually on a day-to-day basis? Truly rare, and we talk about these kind of extreme examples that happen daily across the U.S., the abortion and end-of-life interventions. But when you narrow it down from 5,500 hospitals across the U.S. to one specific floor, to one specific unit, to that one bed where you're working, it's not frequent. So I wonder, how far does that go to creating a workforce and an environment that I, as a healthcare worker, want to work in if someone cares enough to ask me, what are my pinch points? What are my objections?
Right.
I think it would go a long way.
Absolutely. I think that's a really good point too, especially for leaders to kind of think about when they're trying to build their floor, they're trying to build their team, to let them know that there is an out when something isn't following what I believe. So unfortunately, we've come to the end of our time for episode 1, but please join us for episode 2, where Dr. So will continue this discussion, and we're going to really break down some of those individual beliefs versus patient-centered care and some strategies to help us navigate this gray area. Thank you so much for being here for episode 1, Jay. This has been so informative, and I'm really looking forward to continuing this conversation with you in episode 2.
Great, thank you.
This podcast featured content from an accredited CE activity provided by Colibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.